is your narrated PowerPoint for Fluid and Electrolytes, Chapter 16. These are your learning objectives. Okay, so we need to talk about the body's water, how it stays where it's supposed to be, and we will talk about alterations that makes it go into places where it isn't supposed to be. We're not going to go real in depth on all this information because a lot of it you've received before in anatomy and physiology and in your chemistry courses. Our primary focus today is on how to recognize and intervene with patients that are experiencing fluid and electrolyte imbalances. Fluids are vital to all forms of life. They help maintain body temperature and cell shape, and they help transport nutrients, gases, and waste. Just about all major organs work together to maintain proper balance of fluid. To maintain that balance, the amount of fluid gained throughout the day must equal the amount that's lost. Some of those losses can be measured and others can't be. Any change in either the amount of water or electrolytes in the body can affect functions of all cells, tissues, and organs. Body fluids play an important role in transporting nutrients, electrolytes, and oxygen to cells, as well as carrying waste products away from the cells. Your PowerPoint describes to you about how much body fluid is contained. Intracellular is the compartment inside the vessels or inside the cells, and extracellular fluid is the fluid that's contained in the blood vessels or the plasma. About 2/3 of the body's water is located within the body's cells, which makes up about 40% of your body's weight. Other types of fluids that are in the body are lymph system fluid, pleural fluids that are in the lungs, synovial fluids, and the fluids in the joints, your blood and your plasma, GI system fluids and peritoneal fluid, and cerebrospinal fluid. This diagram shows you about how much fluid you take in through the day through drinking food and water, through your body's metabolism, how it is used, and then how it is also excreted, so how the water is lost. There are two types of water loss. Sensible fluid loss is fluid losses from urination, defecation, wound drainage, and other means are referred to as sensible fluid loss. These can be measured. Insensible water loss is usually invisible vaporization from the lungs and the skin, loss of about 600 to 900 mils per day, no electrolyte loss with insensible water loss, and it normally cannot be measured. Excessive sweating is also counted as sensible perspiration. It's usually caused by exercise, fever, or high environmental temperatures, and it may lead to large losses of water and electrolytes. Remember, the body surface area of an infant is greater than that of an adult relative to their respective weights. Because of this difference in body surface area, a higher metabolic rate and a larger percentage of extracellular body fluid and immature kidney function, infants typically lose more water than adults do. With fluid losses, you see increased serum osmolality or increased concentration, high urine osmolality and specific gravity, raised hematocrits, and increased plasma-urea concentration. With fluid gains, you will see reduced plasma-urea and reduced hematocrit. The body holds fluid in two basic areas or compartments, like we discussed a few minutes ago, inside the cells and outside the cells. Fluid found inside the cells is called intracellular fluid, and fluid found outside the cells is extracellular fluid. They are separated by capillary walls and cell membranes. The extracellular fluid consists of three types of fluid. Interstitial fluid, which is located in the spaces between the cells and lymph. Intravascular fluid is fluid inside a blood vessel. It is the fluid portion of the blood, which is plasma, the liquid portion of the blood. Transcellular fluid is like cerebral spinal fluid and fluid in the pleural cavity, the lymph system, and in the joints and eyes. Transcellular fluids generally aren't subject to significant gains or losses throughout the day. To maintain proper fluid balance, the distribution of fluid between the two compartments must remain relatively constant. There are different processes involved when it comes to the movement of water and electrolytes in the body, which includes filtration, diffusion, and osmosis. Capillary filtration is movement of the fluid through capillary walls through hydrostatic pressure, balanced by plasma colloid osmotic pressure from albumin that causes reabsorption of fluid and solutes. Remember, a solute is something that's dissolved, and a solution or solvent is the solvent is dissolved in. Diffusion is the movement of molecules from an area of higher concentration to an area of lower concentration. Osmosis is the movement of only water through a selectively permeable membrane that does not allow solids to cross. This is an example of diffusion. Remember, diffusion moves from higher concentration to lower area of concentration. It is passive. It does not require energy. Movement of the molecule stops when the concentration equalizes. This picture demonstrates active transport. Active transport uses external energy to move molecules against the concentration gradient from an area of low concentration to an area of high concentration. An example is the sodium-potassium pump in cells. This is an example of the sodium-potassium pump. In active transport, the solutes move from an area, again, of lower concentration to higher concentration, like when you're swimming against the current. Active transport does require energy to make this happen. In the sodium-potassium pump, adenosine triphosphate, or ATP, is used to move sodium out of the cell and potassium into the cell. Uptake of glucose in the intestines needs an extra push as well. It needs a carrier molecule, usually a protein, to get across the cell membrane. This is called facilitated diffusion. It does not require energy. This example is osmosis, the movement of just water through a selectively permeable membrane. It does not allow solids to cross. Once particles of water are equal, the movement of water molecules will stop. Osmosis is passive transport. It does not require energy. Water comes in until the molecules are distributed equally. Hydrostatic pressure is what moves whole blood from the heart to the capillaries, where filtration can occur to exchange water, nutrients, and waste products between the blood and the tissue. Edema is an example of when the hydrostatic pressure is different between the capillary blood and the interstitial fluid, such as in patients with right-sided heart failure. Because of the inability of the right side of the heart to pump blood forward to the body, It backs up into the venous system, which causes the hydrostatic pressure to rise until it is higher than the hydrostatic pressure in the intestinal space. Hydrostatic pressure pushes water out of the vascular system or capillaries and into the interstitial tissue space, forming visible edema. Mechanisms for controlling fluid and electrolyte movement. Remember, osmolality and osmolarity are different, as we discussed in class, just different by measurements. Osmolarity is preferred measurement for body type fluids. Osmotic pressure helps to move a solution of water from inside the cell to the outside of the cell. Fluid spacing is the distribution of body water. First spacing is the normal distribution of fluid in the intracellular fluid and the extracellular fluid compartments. It is said to be equal. Second spacing is the abnormal accumulation of interstitial fluid like edema. Remember, the extracellular compartment includes the interstitial fluid, which is the fluid between the cells, and lymph, blood, bone, and connective tissues. Third spacing is when fluid accumulates in areas that normally has no fluid and it's hard to get rid of in those areas. Third spacing is a result of a disease or injury, such as with ascites and edema associated with burns, trauma, or sepsis. In extreme cases, third spacing can cause a relative hypovolemia associated with peritonitis and pancreatitis. Most of the time, the body adequately compensates for minor fluid imbalances and keeps blood pressure readings and other measurements fairly normal. Sometimes, however, the body cannot compensate for fluid deficits or excesses. When that happens, any of several problems may result, including dehydration, hypovolemia, hypervolemia, and water intoxication. Those at risk are going to be your patients that are confused, comatose, and bedridden patients. It also includes infants, especially preterm infants, and patients receiving highly concentrated tube feedings without enough supplemental water. A simple blood pressure measurement taken with a stethoscope and a sphygmomanometer is still one of the best tools for assessing fluid volume. Lab tests for dehydration or hypovolemia may include hematocrit. It's usually elevated with one of these problems, elevated serum osmolality, elevated serum sodium levels, usually above 145, and urine-specific gravity. You will usually see that be above 1.030. Several hormones affect fluid balance, among them the water retainer called antidiuretic hormone, or ADH. The hypothalamus produces ADH, but the posterior pituitary gland stores and releases it. The hypothalamus monitors the amount of water in the body by sensing the concentration of electrolytes in the blood. A high concentration of electrolytes means that the level of water in the body is low. Low concentration of electrolytes means that the level of water in the body is too high. There are 3 hormones that you need to remember that play an important role in fluid balance. Antidiuretic hormone, or ADH, which is produced again in the hypothalamus and is released by the posterior pituitary gland, causes just water to be retained by the kidneys when water levels in the body are low. And this indirectly regulates electrolyte retention or excretion. The hormone aldosterone is produced by the adrenal cortex and prevents both water and sodium loss. When secreted, it triggers the kidneys to reabsorb sodium and water from the urine and put it back into the blood. The hormone natriuretic peptides which are secreted by special cells that line the atria of the heart. Narrated peptides help to decrease circulating blood volume and decrease blood osmolarity. When blood pressure is low, the enzyme renin is released. This splits the protein from angiotensin and genin into angiotensin 1, which is further converted into angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor, and it signals the adrenal cortex to release aldosterone. This aldosterone increases the retention of sodium ions, enhancing the secretion of potassium ions, resulting in water retention and an increase in blood pressure. You won't have to know all of this information specifically or perfectly, but you will need to know and have a good understanding of how the water balances are regulated. To help with regulation of water balance is the thirst mechanism. Thirst is a perception that provides the urge for humans and animals to drink fluids. The thirst mechanism is an example of how osmosis helps maintain homeostasis and ultimately is essential for survival. The feeling of thirst is caused by the activation of cells in the brain that respond to change in extracellular fluid osmolality. When the cell shrinks, this triggers a person's awareness of thirst and increases the urge to drink. Drinking replaces the amount of water lost, restoring it to normal. An increase of 2 to 3% in plasma osmolality will trigger the thirst center of the hypothalamus. Remember, the thirst mechanism is less sensitive in older adults, increasing their risk of dehydration. The kidneys are the major regulator of water and sodium balance. If the body loses even 1 to 2% of its fluid, the kidney takes steps to conserve water. An important step involves reabsorbing more water from the filtrate, which produces a more concentrated urine. The kidneys maintain blood and perfusion pressure to all tissues, organs, and they balance by adjusting urine volume and the urinary excretion of most electrolytes to maintain a balance between overall intake and output. With severely impaired renal function, edema, potassium and phosphate retention, acidosis, and other electrolyte balances may occur. Cardiac regulation, the renin-angiotensin-aldosterone system is involved greatly with the cardiac regulation. When blood volume and blood pressure rise and begin to stretch the atria, the heart's renin-angiotensin-aldosterone system will be shut off, which stabilizes the blood volume and blood pressure. They are natural antagonists to the renin-angiotensin-aldosterone system and are produced in response to increased atrial pressure and high serum sodium levels. These are the peptides that we're talking about. So these peptides actually make the renin-angiotensin-aldosterone system stop. So it quits dropping the blood pressure. And then with it being an antagonist, it makes it stop. So what you end up seeing is the peptides, by promoting excretion of sodium and water, they result in a decreased blood volume and blood pressure. So the hormones there are just kind of a back and forth system. One helps to increase the pressure, one helps to decrease the pressure, and they work back and forth to keep that where it needs to be. Gastrointestinal regulation is with oral intake of fluids, which accounts for most of the water intake. When water intake also includes water from foods, metabolism, and water present in solid foods, that also has to be counted as intake of fluids. Lean meat's about 70% water, whereas the water content of many fruits and vegetables approaches 100%. In addition to oral intake, the GI tract normally secretes about 8,000 mils of digestive fluids each day that is also reabsorbed. We know that diarrhea and vomiting, which can prevent GI reabsorption of secreted fluids, and can lead to significant fluid and electrolyte loss. When caring for patients or older adults, it is important to remember that the older adults are more prone to fluid and electrolyte imbalance due to structural and physiological changes, such as the skin loses its elasticity, turgor, and oil production, which becomes an unreliable indicator of fluid status when you're assessing. It's also one of the first things we assess with hydration. The skin on the back of the hand has lost its elasticity, and the skin is drier due to a decrease in oil production. Changes in the kidneys are a decrease in glomerular filtration and concentrating capacity. Poor excretion of waste products and increased water loss increases the older adult for the risk for dehydration. Muscular changes include decreased muscular mass. Remember, muscle holds more water. The decreased total body mass can result in a decreased total body water and increase the risk for dehydration. Musculoskeletal changes, such as stiffness of the hands and fingers, can lead to a decreased ability to hold a glass or a cup, preventing the older adult from drinking fluids. Neurological changes can result in a diminished thirst reflex. The older adult takes in less fluid, increasing the risk of dehydration. Mental status changes, such as confusion and disorientation, or changes in ambulation status, may lead to a decreased ability to obtain fluids. Endocrine system results in adrenal atrophy. The poor regulation of sodium and potassium increases the risk for hyponatremia and hyperkalemia. Hormonal changes include a decrease in renin and aldosterone and an increase in ADH and AMP. The older adult is more likely to be taking drugs that affect fluid or electrolyte balance. So we definitely need to assess our patients carefully and get a good history. Hypovolemia. All patients are at risk for some degree of fluid imbalance because many health problems can disrupt fluid intake or output. Fluid imbalances can occur in any setting. So know that we have completed a short review of the body's function as it relates to fluid and electrolyte balance. We're going to talk about some problems related to fluid and electrolyte imbalances, and the nursing assessment, diagnosis, interventions, and expected outcomes. Starting with hypovolemia. Hypovolemia is more specifically a decrease in volume of blood plasma and sodium depletion, consequently overlapping with dehydration, which dehydration is an excessive loss of body water only. They are not interchangeable terms, but some treatments may be used for both. Loss of body fluids causes blood solute concentration to increase, which is the same as increased osmolality, and serum sodium levels to rise. So who is at risk? Again, Elderly and the very young patients are highest susceptible to fluid and electrolyte imbalances. Despite the significant age difference, the contributing factors for these imbalances are the same in many cases. Inability to obtain fluid without help, inability to express feelings of thirst, inaccurate assessment of output. For example, patients we talked about wearing diapers and not getting a good output number. Loss of fluid through perspiration because of fever, and loss of fluid through diarrhea and vomiting. Hypovolemia can progress to hypovolemic shock if interventions are not provided to correct the cause, which could be from 40% or more loss in intravascular volume. Excessive fluid loss of normal body fluids, such as hemorrhage, inadequate fluid intake, third space fluid shifting, GI loss, such as vomiting, diarrhea, and decreased fluid intake, excessive use of ibuprofen and other medications, plasma to interstitial fluid shift, chronic malnutrition, or chronic illness. Also from excessive fluid replacement with hypotonic solutions can cause hypovolemia because the hypotonic solutions are pulling the fluid from the extracellular fluid into the cells. So what would the nurse see as an assessment with hypovolemia? Neurologically, we're going to see mental status deterioration, such as confusion due to decreased blood flow to the brain, lethargy, and skeletal muscle weakness. Gastrointestinal, we're going to see increased thirst, cells are dry, we may see constipation, decreased body weight, and diminished bowel sounds. Cardiovascular, we'll see tachycardia. In an attempt to maintain blood pressure, we'll see weak pulses, dysrhythmias due to low volume. We're also going to see delayed capillary refill, again due to low volume. Orthostatic hypotension is a result from insufficient blood flow to the brain. When checking orthostatic hypotension, the patient may become dizzy or lightheaded due to the decreased blood flow to the brain. Respiratory, tachypnea, in order to maintain oxygen delivery due to low volume. Renal, we'll see decreased urine output below 30 mL per hour because of decreased perfusion to the kidneys. Integumentary system is going to have decreased turgor, dry skin, and dry mucous membranes. Laboratory findings will show an elevated hematocrit because of the decrease in fluid volume, an increased BUN, increased sodium, increased urinary specific gravity greater than 1.025, and the urine will be dark amber and have a strong odor. When assessing a patient for possible hypovolemia, it is important to obtain a very good history, as many lifestyle behaviors may contribute to hypovolemia, such as medication history. We're especially looking for diuretics and laxative uses. These increase the risk of hypovolemia. And we want to ask about dietary habits, drinking fluids, how much they drink, their living environment, such as a hot environment, and not having a fan or air conditioner. Older adults do not feel hot, even in the hottest of weather, due to the loss of temperature regulation. We talked about this in class as well. Remember, the elderly, they already have integumentary changes that will not give us or allow us to get a good reading by checking skin turgor in the arm. So other places that you can use is the sternum or the forehead. One diagnostic test that is important to volume status is a urine-specific gravity. Urine-specific gravity measures the urine compared to an equal amount of water. With hypovolemia, the urine-specific gravity will be greater than 1.025. Daily weights is the most accurate measure of volume status. 1 kilogram, which is 2.2 pounds, is equal to 1,000 milliliters. Therefore, when 1 pound of fluid volume change is about 500 mils. So if you have 1 pound of the volume change in fluid, it's going to equal about 500 milliliters. Some nursing diagnoses for hypovolemia include deficient fluid volume, decreased cardiac output, and risk for deficient fluid volume. Potential complications of hypovolemia is hypovolemic shock. So what can we do to help our patients with hypovolemia? We want to ensure that we prevent injury, prevent further fluid loss, and increase fluid volumes to normal. Careful monitoring of intake and output. Intake includes all oral, IV, intraoral, and retained irrigants. Output includes urine, excess perspiration, wound or tube drainage, vomiting, and diarrhea. Obtain a urine-specific gravity to check. Readings, again, of greater than 1.025 indicate concentrated urine, which indicates a volume problem. Be sure and monitor sodium levels. Levels above 145 indicate a low fluid volume. You want to take a blood pressure about every 4 to 8 hours. For orthostatic hypotension may be evident in patients with fluid volume deficit. Safety is important as the patient with orthostatic hypotension are at risk for falls due to weakness, unsteady gait, and decreased level of alertness. Assessing respiratory status with fluid volume deficit will demonstrate an increased respiratory rate as a result of decreased tissue perfusion and resultant hypoxia. Assess the patient's level of consciousness, pupillary response, and voluntary movements of extremities. Change could mean that the hypovolemia is worsening and would, as with the sodium, would also be increasing. Weigh the patient at the same time every day with the same garments and on the same carefully calibrated scale. Medication to treat the possible underlying cause, such as, or medicate, such as antidiarrheal drugs for diarrhea and antiemetics for nausea and vomiting, if that is the problem. IV fluids is ordered for your doctor according to the cause. If it's related to blood loss or hydration problems, it would be isotonic solutions such as 0.9% normal saline to restore the volume. If it's related to disease process, such as hyponatremia, you would need a hypertonic solution. If it's related to blood loss, blood products may not be needed. Expected outcomes, we'd like to see moist mucous membranes, decreased confusion, blood pressure drops to what would be the patient's normal value, skin turgor improved, improved level of consciousness, respiratory rate is slower, improved urine output greater than 30 mils per hour, and specific gravity is less than 1.025. So the blood pressure should return to the patient's normal value. Hypervolemia is an excess of isotonic fluid, which is water and salt or sodium in the extracellular compartment. Fluid volume excess, hypervolemia, is a clinical indication of a problem in which fluid intake or retention is greater than the body's fluid needs. Causes could be from excessive intake of fluids, abnormal retention of fluids caused by heart failure or renal failure, or a shift of fluid from interstitial fluid to plasma fluid, increasing intravascular volume. Long-term corticosteroid therapy, excessive sodium ingestion, early renal failure, inadequately controlled IV therapy are also problems. Heart failure and pulmonary edema may result. Fluid is forced out of the blood vessels and moves into the interstitial spaces. This causes edema in the tissues. So what would you assess in a patient that is hypervolemic? Gastrointestinal-wise, you want to assess for acute weight gain related to the retained fluid, increased motility in the GI tract, and ascites. Remember, for every 2 pounds gained means 1,000 mils of retained fluid is on board. For every 1 pound gain, 500 mils is retained fluid. 2.2 pounds equals 1 kilogram, which is the same as 1,000 mils. Cardiovascular, you're going to see bounding and increased pulse rate, distended neck veins, and possible dysrhythmias. Respiratory, you're going to see crackles in the lungs due to the pulmonary congestion. Fluid has nowhere to go. You're going to see dyspnea and tachypnea. Integumentary system, you're likely to see edema, which is the fluid in the interstitial spaces. The patient is going to be pale and have cool skin. The vessels are deeper in the tissue, so blood flow is more impaired. Neurologic changes that you may see are because of the swelling of the cells and fluid in spaces where it's not supposed to be. Altered level of consciousness, headache, skeletal muscle weakness, and paresthesia. Renal, you're going to see increased urine output. And lab findings will show a decrease in sodium levels due to the extra fluid. Sodium will be less than 135 because the water has the sodium so diluted. Hematocrit will be decreased because of excess water. Decreased urine specific gravity, and a patient in fluid overload is at risk for pulmonary edema, heart failure, and complications of electrolyte dilution. The patient with hypervolemia has excess fluid volume related to increased water and or sodium retention. Impaired gas exchange. It's the impaired gas exchange related to water retention leading to pulmonary edema. Edema puts the patients at risk for impaired skin integrity or skin breakdown. Increased water retention, fatigue, and weakness can lead to activity intolerance. And the patient with excess fluid volume is at risk for ascites. The focused priority nursing interventions for fluid overload is to ensure patient safety, restore normal fluid balance, and prevent future fluid overload. Assess lung sound and respirations at least every 4 hours because pulmonary edema can occur quickly. Administer oxygen for nasal cannula. Reposition the client at least every 2 hours, if not more. Edema puts them at high risk for skin breakdown. Assess skin pressure areas, often for signs of redness or open areas, especially the coccyx, elbows, hips, and heels. Administer diuretics such as furosemide if kidney failure is not the cause. Monitor the response through intake and output, laboratory findings, especially sodium and potassium levels. Weigh your patient daily on the same scale, same clothes as we discussed earlier. Fluid and sodium restrictions, salt restrictions according to severity of the fluid overload. If severe, limit to 2 grams per day. Fluid may or may not be restricted according to the cause. Restrictions usually are about 1,200 mils per day divided over 3 shifts, or it may be 500 mils less than the urinary output for the last shift or the last 24 hours. So expected outcomes that we want to see is a decrease in the weight, lungs clear, intake and output are going to be balanced, decreased edema, and no skin breakdown. Electrolytes. Remember, electrolytes conduct energy, regulate fluid balance, transport nutrients, support proper muscle function, support mental function, and help to convert calories into energy, and much, much more. They are very important to the body. Foods high in electrolytes include dairy products, soy milk, squash, cheese, green leafy vegetables, pickles, coconut water, and celery. Sodium is a mineral in the extracellular fluid and maintains extracellular fluid osmolality. Sodium plays a major role in extracellular fluid volume and concentration, generation and transmission of nerve impulses, muscle contractility, and acid-base balance. The kidneys are the primary regulator of sodium balance. The extracellular fluid sodium level determines whether water is retained, excreted, or moved from one fluid space to another. Sodium leaves the body through urine, sweat, feces, draining wounds, trauma, and some medications. Sodium is the main cation of extracellular fluid. Normal sodium levels are 125 to 145. Hyponatremia is when the sodium levels drop below 135, and hypernatremia is a sodium level greater than 145. So what would you see with this problem? The most obvious are the effects on the cerebral and neuromuscular functions. Manifestations include with the central nervous system, confusion, irritability, headaches, seizures, lethargy, and coma. Neuromuscular changes are general muscle weakness noted by deep tendon reflexes being diminished, and weakness in legs and the arms. You can have patients squeeze your hands to check extremity strength. Don't forget DTRs. We'll check more than that, deep tendon reflexes. If muscle weakness is present, immediately check respiratory effectiveness because ventilation depends on adequate strength of respiratory muscles. Interstitial changes include nausea, diarrhea, intestinal changes include nausea, diarrhea, increased motility, and hyperactive bowel sounds with frequent water bowel movements. Cardiovascular changes occur rapidly. You may see weak, thready pulse and decreased blood pressure along with dizziness. In the renal system, increased urinary output. Laboratory findings include sodium levels less than 135 milliequivalents per liter and decreased urinary specific gravity. If sodium drops below 120 milliequivalents per liter, this is considered severe, which could result in brainstem herniation, respiratory arrest, and death. Nursing diagnoses related to hyponatremia include acute confusion, risk for injury, risk for electrolyte imbalance. Potential complications include severe neurological changes. In mild hyponatremia caused by water excess, wait a minute, hold on. I lost my place. Okay, in mild hyponatremia that is caused by water excess, fluid restriction is often the only treatment. If hyponatremia is acute or more serious, small amounts of IV hypertonic saline solution, such as 3% sodium chloride, can restore the serum sodium level while the body is returning to a normal water balance. Treatment of hyponatremia that's associated with abnormal fluid loss includes fluid replacement with sodium-containing solutions. Vasopressor receptor antagonists, or drugs that block the activity of ADH, are used to treat patients who cannot tolerate fluid restrictions or have more severe symptoms. Conivaptan or Viprisol results in increased urine output without loss of electrolytes such as sodium and potassium. It should not be used in patients with hyponatremia from excess water loss. Tolvaptan is an oral agent used to treat hyponatremia associated with heart failure, liver cirrhosis, and the syndrome of inappropriate antidiuretic hormone secretion, or SIADH. Hypernatremia is not a problem in an alert person who has access to water, has a sense of thirst, and is able to swallow. Hypernatremia is when the sodium is greater than 145 milliequivalents per liter. Causes that result in hypernatremia are usually secondary to water deficiency as a result of impaired level of consciousness or an inability to obtain fluids. It can also be caused by some medications, like seizure medications, one being phenytoin, because phenytoin inhibits the effects of the ADH release. NSAIDs can cause polyuria, which results in low fluid volume, and also furosemide. Medications that contain sodium, such as acetaminophen and Alka-Seltzer, increase sodium levels in the body. Disease process, such as diabetes insipidus, which is a condition causing a water imbalance in the body, leading to excretion of larger than normal amounts of urine, along with increased thirst, even after drinking plenty of fluids. Also, excessive sodium intake with inadequate water intake, IV administration of hypertonic saline or sodium bicarbonate, and excessive oral intake of sodium, such as with ingestion of seawater. Patients on NPO status, if they have a fever, infection, or a lot of watery diarrhea, loss of water, but not sodium. Although symptomatic hypernatremia is rare, it does occur. When symptoms do occur, they are primarily the result of water shifting out of the cells and into the extracellular fluid, which results in shrinkage of cells, leading to neurologic manifestations. So what are you going to see? Signs and symptoms will vary with the severity of sodium imbalances and whether the fluid imbalance is also present. Neurologically, you're going to see altered cerebral function, impaired level of consciousness, seizures, agitation, lethargy, and drowsiness. Neuromuscular, you'll see muscles twitching, irregular muscle contractions, weakness, deep tendon reflexes are reduced or absent. The weakness will occur bilaterally. Cardiovascular, decreased contractility, heart rate, and blood pressure responses to vascular volume status, and neck veins may be distended. Pulse rate increased with hypernatremia and hypovolemia. Integumentary system, you're going to see dry and flushed skin, dry and sticky tongue, and mucous membranes, and edema. Laboratory findings include serum sodium level that exceeds 145 milliequivalents per liter, increased urinary specific gravity. Sodium and water loss. A water deficiency can occur alone, or it can occur with the loss of sodium. But usually more water is lost than sodium. In either case, serum sodium levels are elevated. A water deficit can cause hypernatremia, more sodium relative to the water in the body. Severe watery diarrhea and vomiting are other causes of water loss and subsequent hypernatremia. This is a compensatory mechanism. Nursing diagnosis for patients with hypernatremia are associated with the patient's decreased neurologic status. These include risk for injury due to the seizures, coma, risk for fluid volume deficit resulting from water loss, and risk for electrolyte imbalance resulting from sodium or electrolyte imbalances. Managing hypernatremia depends on the underlying cause and the patient's volume status. In primary water deficit, fluid replacement is provided either orally or with IV isotonic solutions such as 0.9% sodium chloride. If the problem is sodium excess, expect diluting the high sodium concentration with sodium-free IV fluids, such as 5% dextrose in water, and promoting sodium excretion with diuretics. Monitor serum sodium levels, serum osmolality, and the patient's response to therapy. The serum sodium levels should not decrease by more than 8 to 15 milliequivalents per liter in an 8-hour period. Quickly reducing levels can cause a rapid shift of water back into the cells, resulting in cerebral edema and neurologic complications. This risk is greatest in the patient who has developed hypernatremia over several days or longer. Drug and nutrition therapies are used to prevent further sodium increases and to decrease high serum sodium levels. And intake and output record for 24 hours is needed. Fluid replacement is either orally or with IV, usually with isotonic 0.9% normal saline or hypotonic solutions such as 0.45% normal saline, according to the cause of hypernatremia. Daily weights to ensure that the patient is getting the correct amount of fluids, because if the patient isn't, the sodium level will continue to rise. Obtain the urine specific gravity. A level of 1.0025 indicates low water levels, which this is the case with hypernatremia. Healthcare may provide healthcare may provide prescribed sodium-free IV fluids, such as 5% dextrose in water to dilute the sodium concentration in the body. Provider may also prescribe diuretics like furosemide or Rumex to promote excretion of excess sodium. Dietary consult to assist with diet to decrease the sodium intake to about 2 grams per day. Expected outcomes, we want to see sodium level within the normal limits of 135 to 145, moist mucous membranes, no tinting, improved skin turgor, alert and oriented, good strength, present deep tendon reflexes, decreased thirst, blood pressure, heart rate, and respirations back to normal levels for the person. Okay, potassium. Potassium is a major intracellular fluid cation, with 98% of the body potassium being intracellular. Potassium is involved with regulating intracellular osmolality and promoting cellular growth. Potassium is required for glycogen to be deposited in muscle and liver cells. Potassium deficit is potentially life-threatening because every body system is affected, especially the neuromuscular and cardiac systems. The ratio of extracellular fluid to intracellular fluid potassium is the major factor in the resting membrane potential of nerve and muscle cells. Life-threatening reactions develop when the extracellular fluid potassium moves above or below the normal range of 3.5 to 5 milliequivalents per liter. The sodium-potassium pump in cell membranes maintains the concentration difference by pumping potassium into the cell and sodium out. Hypokalemia diet is a source of potassium, which comes mainly from fruits, even dried fruits, vegetables, and protein-rich foods. Many salt substitutes used in low sodium diets contain substantial amounts of potassium. If kidney function is significantly impaired, retained potassium can lead to toxic levels. The kidneys are the primary route for potassium loss, eliminating about 90% of the daily potassium intake. Hypokalemia. Since 98% of the total body potassium is inside the cells, minor changes in extracellular potassium levels cause major changes in the excitability of the cell membrane. The most common cause of hypokalemia are abnormal losses from the kidneys or the GI tract, or when potassium intake is not adequate to match normal potassium loss. GI tract losses of potassium are associated with diarrhea, laxative abuse, vomiting, ileostomy, drainage, prolonged nasogastric suctioning, and wound drainage. Low plasma magnesium stimulates renin release and subsequent increased aldosterone levels, which results in potassium excretion. Factors that cause sodium retention, such as low blood volume, increased aldosterone levels, cause potassium loss in the urine. This is the sodium-potassium pump. Large urine volumes can be associated with excess loss of potassium in the urine. As stated earlier, most signs and symptoms of hypokalemia involve changes in the cardiac and muscle function. So what would you see or assess for? Neuromuscularly, you will see anxiety, confusion, skeletal muscle weakness, flaccid paralysis, paresthesias, deep tendon hyperreflexia, and problem solving in simple task problems. Respiratory, severe hypokalemia can cause weakness or paralysis of the respiratory muscles, leading to shallow respirations and eventually respiratory arrest. Gastrointestinally, you're going to see decreased GI motility. Paralytic ileus is possible. You're going to see hypoactive to absent bowel sounds, nausea and vomiting, and constipation, and abdominal distension. Cardiovascular, thready weak pulse, irregular pulse, weak peripheral pulses, and orthostatic hypotension, along with dysrhythmias. Drugs, especially diuretics, corticosteroids, and beta adrenergic can increase potassium losses to the kidneys. Diseases and injuries can lead to potassium loss. Laboratory findings include serum potassium levels lower than 3.5 milliequivalents per liter, ECG changes, ST depression, flat or inverted T waves. ECG changes in the ECG changes with hypokalemia include ST segment depression, flat or inverted T waves. Dysrhythmias can lead to death, particularly in older adults who are taking digoxin. There's an increased incidence of potentially lethal ventricular dysrhythmias. So what nursing diagnoses would be appropriate for hypokalemia? We're going to see risk for activity intolerance and injury related to the muscle weakness and hyporeflexia, and risk for cardiac dysrhythmias. Also risk for injury, electrolyte imbalance. Interventions for hypokalemia focus on correcting the underlying cause, preventing potassium loss, increasing serum potassium levels, and ensuring patient safety. Priority is ensuring adequate oxygenation, so be sure to place your patient on oxygen. Treatment of hypokalemia consists of oral or IV potassium chloride supplements and increased dietary intake of potassium. Diets high in potassium, examples are raisins, tomato juice, prunes, and bananas. If giving oral potassium, give during or after meals. Do not administer on an empty stomach because it can cause nausea and vomiting. If potassium is in pill form, it should not be crushed. It doesn't absorb correctly when it is crushed. Be sure and mix in fluid. If urine output is below 0.5 mils per kilogram of body weight per hour, potassium supplements should not be given. The reason is potassium is excreted via the kidneys. If kidneys are not functioning correctly, potassium will build up in the system. If taking diuretics, it should be a potassium-sparing diuretic, such as spironolactone, to help conserve that potassium. If giving IV potassium chloride, it must always be diluted and never given in concentrated amounts. The rate of IV administration of potassium chloride should not exceed 10 to 20 milliequivalents per hour and must be administered by an infusion pump to ensure correct administration rate. This rate is never to exceed 20 milliequivalents per liter under any circumstances. The preferred maximum concentration is 40 milliequivalents per liter. However, stronger concentrations may be given for severe hypokalemia, up to 80 milliequivalents per liter, with continuous cardiac monitoring being necessary. Patients should have cardiac monitoring to detect cardiac changes related to potassium imbalances. Potassium is lost through stool. A patient with Clostridium difficile will have severe diarrhea, so the patient is at risk for hypokalemia. A patient with continuous nasogastric suctioning would be at risk for actual potassium loss, leading to hypokalemia. The other patients are at risk for potassium excess or hyperkalemia. Never give potassium chloride as an IV push or as a bolus. So with administering potassium chloride, this is according to the National Patient Safety Goals. Always use an IV pump. Before infusing an IV solution containing potassium chloride, check and recheck the dilution of the drugs in the IV solution container. Never add potassium chloride to a hanging IV bag to prevent giving the patient a bolus dose. Invert the bag several times. Potassium is never given IV push to avoid causing cardiac arrest. Because potassium chloride is irritating to the vein, assess IV sites at least hourly for phlebitis and infiltration. Infiltration can cause necrosis and sloughing of the surrounding tissue. Okay, moving on to hyperkalemia. Hyperkalemia is an electrolyte imbalance in which the serum potassium level is greater than 5.0 milliequivalents per liter. Hyperkalemia is rare in people with normal kidney function. Most common cause of hyperkalemia is renal failure. Adrenal insufficiency causing aldosterone insufficiency can also cause potassium retention. Most cases of hyperkalemia occur in hospitalized patients and in those undergoing medical treatment, chronically ill patients, debilitated patients, and older adults. Medications can cause hyperkalemia, such as NSAIDs, because of the potassium in the medications. Acidosis, massive cell destruction, as in burn or crush injury, tumor lysis, and severe infections, and exercise can lead to a shift of potassium from the intracellular fluid to the extracellular fluid, which is increasing the serum levels. Potassium-sparing diuretics like amiloride, spironolactone, angiotensin II receptor blockers such as losartan, and angiotensin converting enzyme or ACE inhibitors like enalapril and lisinopril may contribute to the development of hyperkalemia by reducing the kidney's ability to excrete the potassium. So what do we need to assess for with hyperkalemia? Hyperkalemia increases the concentration of potassium outside of the cell, altering the normal extracellular and intracellular ratio, resulting in increased cellular excitability. So again, many of the signs and symptoms are related to cardiovascular and neuromuscular changes. Respiratory, we're going to see profound weakness of the skeletal muscles. And this can lead to respiratory failure. Neuromuscular, as the levels of potassium increase, the patient may experience cramping, leg pain, and weakness, tingling and burning sensation followed by numbness in the hands and feet and around the mouth, which is a paresthesia, followed by weakness or paralysis of other skeletal muscles, including the respiratory muscles and cardiac muscles. Cardiovascular, we see slow, weak, irregular heart rate, bradycardia, hypotension, and chest pain related to ECG changes of tau and peak T waves, prolonged PR intervals, and flat or absent P waves. Gastrointestinal, increased motility, hyperactive bowel sounds, diarrhea, and abdominal cramping. Laboratory findings include serum potassium level that exceeds 5.1 milliequivalents per liter, ECG changes, which include tall peak T waves, widened QRS complexes, and prolonged PR intervals. The most clinically significant manifestations of hyperkalemia are the disturbances in cardiac conduction. A flat P wave and widening of the QRS complex may be present. Shortening of the QT interval and causing the T wave to be narrower and more peaked. If potassium level is not restored to normal levels, ventricular fibrillation or cardiac standstill may occur. The patient with hyperkalemia is at risk for activity intolerance and injury related to lower extremity muscle weakness. They're at risk for electrolyte imbalance, risk for injury, and potential complications include dysrhythmias. When the elevation of potassium is mild and the kidneys are functioning, it may be sufficient to withhold potassium from the diet and IV sources and increase renal elimination by administering fluids and possibly diuretics. Stop oral and parenteral potassium intake. Polystyrene sulfonate or KX-Lex is administered orally or rectally. This is a cation exchange resin that promotes GI sodium absorption and potassium excretion. Patients with moderate hyperkalemia should receive IV administration of hypertonic dextrose with regular insulin to help move excess potassium back into the cells. All patients with clinically significant hypercalcemia should be placed on telemetry to detect dysrhythmias and to monitor the effects of therapy. The patient experiencing dangerous cardiac dysrhythmias should receive IV calcium gluconate immediately. Monitor blood pressure because rapid administration of calcium can cause hypotension. If the heart rate drops below 60 beats per minute or the T waves become spiked, both of which accompany hyperkalemia, the healthcare provider and/or rapid response team should be notified. Avoid salt substitutes, potassium-restricted diet, increased fluid intake. IV solutions are hypertonic. Health teaching is the key to the prevention of hyperkalemia and the early detection of complications. Teaching should include avoiding foods high in potassium, instruct the patient and family to read the labels on drug and food packages to determine the potassium content. Warn them to avoid salt substitutes which contain potassium. So what are expected outcomes that we want to see with hyperkalemia? These would include ECG changes that are back to normal, decreased potassium levels, and improvement in muscle tone, no weakness. Okay, the answer is C. Potassium causes musculoskeletal change, such as weakness, twitching, cramps, which puts them at risk for injury or falls. Also, the musculoskeletal changes put the patient at risk for respiratory insufficiency because of the muscle weakness. The diuretics or laxatives could cause decreased levels of potassium, but not the most important question for the nurse to ask. Respiratory is a higher priority. Muscle weakness can result in respiratory problems. When a question has most or priority, or highest, and first, these are priority questions, and all answers most of the time are correct, but you have to make the clinical judgment in which one to do first. Calcium is necessary for many metabolic processes. It is a major cation in bones and teeth. Calcium plays a role in blood clotting, transmission of nerve impulses, myocardial contractions, and muscle contractions. Total body calcium is about 1,200 grams. 99% of calcium is in the bone and teeth. The rest is in the plasma and extracellular fluid. The source of calcium is dietary intake. Calcium absorption requires the active form of vitamin D. Vitamin D is either ingested in the diet or is obtained from foods or made in the skin by the action of sunlight on cholesterol. Foods high in calcium include milk and spinach. Calcium is present in the serum in three forms, either free or ionized, bound to protein, primarily albumin, and the remainder is found bound with phosphate, citrate, or carbonate. The ionized or free calcium is biologically active. Total serum calcium levels reflect the total calcium level, all three forms, although ionized calcium levels may be analyzed and reported separately. Changes in serum pH will alter the level of ionized calcium without altering the total calcium level. A decreased plasma pH or acidosis decreases calcium binding to the albumin, leading to more ionized calcium. An increased plasma pH or alkalosis increases calcium binding, leading to decreased ionized calcium. Alterations in serum albumin levels affect the interpretation of total calcium levels. Low albumin levels result in a drop in the total calcium level, although the level of ionized calcium is not affected. Parathyroid hormone, PTH, and calcitonin regulate calcium levels. PTH production and release are stimulated by low serum calcium levels. PTH increases bone reabsorption or movement of calcium out of the bone and increases GI absorption of calcium and increases renal tubule reabsorption of calcium. Calcitonin is produced by the thyroid gland and is stimulated by high serum calcium levels. It opposes the action of PTH and lowers the level of serum calcium by decreasing GI absorption, increasing calcium deposits into bone, and promoting renal excretion. Hypercalcemia is caused by hyperparathyroidism in about 2/3 of the cases. Malignancies, especially from hematologic breast and lung cancers, cause the remaining third. Malignancies lead to hypercalcemia through bone destruction from tumor invasion or through tumor secretion of a parathyroid related protein, which stimulates calcium release from bones. More rare causes include thiazide diuretic use, prolonged immobilization, and increased calcium intake, which may include dietary and the use of calcium-containing antacids. Excess calcium acts like a sedative, leading to reduced excitability of both muscles and nerves. Neurologic manifestations begin with fatigue, lethargy, weakness, and confusion, and progress to hallucinations, seizures, and coma. Disturbances in cardiac conduction can lead to dysrhythmias, including heart block and ventricular tachycardia. Nursing diagnoses that are associated is excessive bone destruction can lead to or worsen the electrolyte imbalance. So you have a risk for electrolyte imbalance. Patients with hypercalcemia are at risk for activity intolerance and injury related to generalized muscle weakness and neuromuscular and sensorium changes. The patient with hypercalcemia is also at risk for dysrhythmias caused by decreased myocardial excitability. The basic treatment of hypercalcemia is promoting urinary excretion of calcium by administering a loop diuretic such as furosemide and hydrating the patient with isotonic saline infusions. The patient must drink 3,000 to 4,000 milliliters of fluid daily to promote the renal excretion of calcium and decrease the possibility of kidney stone formation. Other supportive measures include a diet low in calcium and an increase in weight-bearing activity to enhance bone mineralization. Biphosphonates, such as pamidronate, zoledronic acid, are the most effective agents in treating hypercalcemia as a result of malignancy. They interfere with the ability of activity of osteoclasts, cells that break down bone. Because it takes 2 to 4 days for these to achieve maximum effects, patients receive intramuscular or subcutaneous calcitonin for an immediate effect. Calcitonin rapidly increases renal calcium excretion. However, therapy is only effective for a few days and may cause tachycardia. IV saline therapy requires careful monitoring for fluid overload. Dialysis is an option in life-threatening situations. Hypocalcemia can result from any condition associated with parathyroid hormone deficiency. This may occur with surgical removal of a portion of or injury to the parathyroid glands during the thyroid or neck surgery or with neck radiation. The patient who receives multiple blood transfusions can become hypocalcemic because the citrate used to anticoagulate the blood in the bag binds with the calcium, decreasing the levels. Sudden alkalosis may also result in symptomatic hypocalcemia despite a normal total serum calcium level. The high pH increases calcium binding to protein, decreasing the amount of ionized calcium. Low levels of calcium allow sodium to move into excitable cells, decreasing the threshold of action potentials with subsequent depolarization of the cells. This results in increased nerve excitability and sustained muscle contraction called tetany. A positive Trousseau's or Chauvistic sign is indicative of hyperreflexia, noted with hypercalcemia. Excess neuromuscular excitability causes other clinical manifestations, including stridor, dysphagia, paresthesia, and numbness and tingling around the mouth or in extremities. Cardiac effects of hypocalcemia include decreased cardiac contractility and ECG changes. A prolonged QT interval may develop into a ventricular tachycardia. Serum calcium levels well above the normal level puts the patient at risk for cardiac dysrhythmias. Chauvistic sign is contraction of facial muscles in response to a light tap over the facial nerve in front of the ear. And Trousseau's sign is a carpal spasm that's induced by inflating a blood pressure cuff 20 millimeters of mercury above the systolic pressure and holding it there for 3 minutes. Nursing diagnoses for patients with hypocalcemia. Laryngeal spasm can cause ineffective breathing patterns. The patient with hypocalcemia may experience acute pain related to sustained muscle contractions. The patient is at risk for injury related to tetany and seizures. Patients need to be monitored for potential fractures and respiratory arrest related to decreased levels of calcium. The primary goal of treatment for hypocalcemia is to treat the underlying cause. Treating mild or asymptomatic hypocalcemia involves a diet high in calcium, rich foods, and calcium and vitamin D supplementation. Symptomatic hypocalcemia is treated with IV calcium gluconate. Measures to promote carbon dioxide retention, such as breathing into a paper bag or sedating the patient, can control muscle spasms and other symptoms of tetany until the calcium level is corrected. Patients taking loop diuretics may need to change to thiazide diuretics to decrease urinary calcium excretion. Adequately treat pain and anxiety because hyperventilation-induced respiratory alkalosis can precipitate hypocalcemic symptoms. Phosphate. Phosphorus is a primary anion in the intracellular fluid and the second most abundant element in the body after calcium. Most phosphorus is in the bones and teeth as calcium phosphate. The remaining phosphorus is metabolically active and essential to the function of muscle, red blood cells, and the nervous system. It is also involved in the acid-base buffering system, the mitochondrial formation of ATP, cellular uptake and use of glucose, and in carbohydrate, protein, and fat metabolism. Parathyroid hormone maintains serum phosphorus levels and balance. Proper phosphate balance requires adequate renal functioning because the kidneys are the major route of phosphate excretion. When the phosphate levels in the glomerular filtrate falls below the normal level or the parathyroid hormone levels are low, the kidneys reabsorb additional phosphorus. A reciprocal relationship exists between phosphorus and calcium. in that a high serum phosphate level tends to cause a low calcium concentration in the serum. This means that low serum calcium levels stimulate the release of parathyroid hormone, decreasing reabsorption of the phosphorus and lowering phosphorus levels. Hyperphosphatemia is commonly caused by acute kidney injury or chronic kidney disease, which alter the kidney's ability to excrete the phosphate. Other causes include excess phosphate intake from the use of phosphate-containing laxatives or enemas, or a shift of phosphate from the intracellular to the extracellular fluids. This may occur in patients with tumor lysis syndrome or rhabdomyolysis. Hypoparathyroidism and vitamin D intoxication cause increased kidney phosphate reabsorption. Hyperphosphatemia is often asymptomatic unless calcium binds with phosphate, leading to manifestations of hypocalcemia. These manifestations include tetany, muscle cramps, paresthesias, and seizures. Long-term increased phosphate levels result in the development of calcified deposits outside of the bone. These calcium deposits can be found in soft tissues such as joints, arteries, skin, corneas, and kidneys, and produce organ dysfunction, notably renal failure. The primary management of hyperphosphatemia is identifying and treating the underlying cause. Ingestion of foods and fluids high in phosphorus, such as dairy products, should be restricted. Oral phosphate binding agents or gels like calcium carbonate limit intestinal phosphate absorption and increase phosphate secretion into the intestine. With severe hyperphosphatemia, hemodialysis can rapidly decrease levels. Volume expansion and forced diuresis with a loop diuretic may increase phosphate excretion. If hypocalcemia is present, instituting measures to correct calcium levels assists with returning phosphorus levels to normal. I'm going to step away for just a second. Okay, so I'm back with hypophosphatemia, low serum phosphate, and can result from decreased intestinal absorption, increased urinary excretion, or from extracellular fluid to intracellular fluid shifts. Malabsorption, diarrhea, and phosphate binding antacids lead to decreased absorption. Hypophosphatemia may also occur in those who are malnourished or receive parenteral nutrition and inadequate phosphate replacement. Most of the manifestations of hypophosphatemia result from impaired cellular energy and oxygen delivery related to deficient cellular ATP and 2,3-diphenoglycerate, an enzyme in red blood cells that facilitates oxygen delivery to the tissues. Mild to moderate hypophosphatemia is often asymptomatic. Severe hypophosphatemia may be fatal because of decreased cellular function. Acute manifestations include central nervous system depression, muscle weakness and pain, respiratory failure, and heart failure. Chronic hypophosphatemia alters bone metabolism, resulting in rickets and osteomalacia. Managing mild phosphorus deficiency involves increasing oral intake with dairy products or phosphate supplements. Dairy products are better tolerated as phosphate supplements and are often associated with adverse GI effects. Symptomatic hypophosphatemia can be fatal and often requires IV administration of sodium phosphate or potassium phosphate. Frequent monitoring of serum phosphate and calcium levels is necessary to guide IV therapy. Sudden symptomatic hypocalcemia, secondary to increased calcium phosphorus binding, is a potential complication of IV phosphorus administration. Magnesium is the second most abundant intracellular cation. Magnesium plays an important role in many essential cellular processes. The most notable is the activation of a wide variety of enzyme systems. Magnesium is a coenzyme in the metabolism of carbohydrates and protein and is required for the synthesis of nucleic acid and proteins. Magnesium plays a role in maintaining normal calcium and potassium balance. Manifestations of magnesium imbalances are often mistaken for calcium imbalances. Because magnesium, calcium, and potassium balance are closely related, assess all three cations together. Adequate intracellular magnesium is necessary for normal function of the sodium-potassium pump. Hypermagnesemia usually occurs only with an increase in magnesium intake accompanied by renal insufficiency or failure. A patient with chronic kidney disease who ingests products containing magnesium, such as Maalox or milk of magnesia, will have a problem with excess magnesium. Magnesium excess could develop in the pregnant woman who receives magnesium sulfate for the management of preeclampsia and eclampsia. Be sure to check DTRs. Excess magnesium inhibits acetylcholine release at the myoneural junction and calcium movement into cells, impairing nerve and muscle function. Initial manifestations include hypotension, facial flushing, lethargy, urinary retention, nausea, and vomiting. As the serum magnesium level increases, deep tendon reflexes are lost, followed by muscle paralysis and coma. Respiratory and cardiac arrest can occur. Management begins with avoiding drugs that contain magnesium and limiting diet intake of magnesium-containing foods such as green vegetables, nuts, bananas, oranges, peanut butter, and chocolate. If renal function is adequate, promoting urinary excretion with oral and parenteral fluids and IV furosemide decreases magnesium levels. If hypermagnesemia is in the patient with impaired renal function, it will require dialysis because the kidneys are the major route of excretion for magnesium. Symptomatic giving IV calcium gluconate will oppose the effects of the excess magnesium on cardiac muscle. Magnesium is used in preterm labor or in preeclampsia to relax contractions or decrease blood pressure. Be sure and assess DTRs during magnesium administration in order to catch hypermagnesemia before leading to respiratory or cardiac arrest. So your DTRs, as from my experience, is one of the biggest things that helps you decide if your patient is getting overloaded with magnesium. And it gives you, as long as they still have positive DTRs, it gives you enough time to correct it before they quit breathing. So it's very serious. Hypomagnesemia occurs in patients with limited magnesium intake or increased renal losses. Major causes of hypomagnesemia from insufficient food intake include prolonged fasting or starvation and chronic alcoholism. So everybody heard that, right? Hypomagnesemia goes along with chronic alcoholism. Fluid loss from the GI tract interferes with magnesium absorption. And another potential cause of hypomagnesemia is prolonged parenteral nutrition without magnesium supplementation. Many diuretics increase the risk of magnesium loss through renal excretion. In addition, osmotic diuresis caused by high glucose levels in uncontrolled diabetes mellitus increases renal excretion of magnesium. Clinically, hypomagnesemia resembles hypocalcemia. Neuromuscular manifestations are common, such as muscle cramps, tremors, hyperactive deep tendon reflexes. Spastic sign and Trousseau sign neurologic manifestations include confusion, vertigo, and seizures. Magnesium deficiency can lead to cardiac dysrhythmias, such as ventricular fibrillation. Hypomagnesemia is associated with digitalis toxicity. The primary goal of treatment for hypomagnesemia is to treat the underlying cause. Mild magnesium deficiencies involve oral supplements and increased dietary intake of foods high in magnesium, such as green vegetables, nuts, bananas, oranges, peanut butter, and chocolate. If hypomagnesemia is severe or if hypocalcemia is present, IV magnesium, such as mag sulfate, is usually given. Monitor vital signs and use an infusion pump, as too rapid administration of magnesium can lead to hypotension and cardiac or respiratory arrest. I added this onto the